us today. And today he'll be talking about superior capsular reconstruction. And then without further ado, I will let him begin his talk today. Dr. Mihata? Oh, I'm sorry, I've forgotten to mention our commentator, Dr. Adinun, and he'll be our commentator and will conduct the questioning and Q&A after Dr. Mihata's talk. Thank you.
Okay.
Dr. Mihata?
Can I start? Can you see my slides?
Yeah.
Okay.
Good.
Okay, I'm starting. I'm Teruhisa Mihata, Osaka Medical and Pharmaceutical University, Japan. My talk is supercapsular reconstruction for massive road cuff chairs. Here's my disclosure. We developed a new surgical treatment of supercapsular reconstruction for irreparable cuff chair in 2007. This is an animation movie. We insert the two suture anchor on the grinder. Usually it's a 4.5 millimeter, and laterally my prefer is a speed brace, and all sutures and fiber tape attached outside the body then not tying on the grinder first, and laterally speed brace with medial mattress suture, and finally set the suture between graft and tendon. Also, I'm showing how to make a fasciolata graft. This is a fasciolata. Fasciolata has an intermuscular septum there. If you include intermuscular septum, it's a two tendon tissue. Then we can make a thick graft. We sandwich this intermuscular septum in between two layers and medial mattress suture, very important to make stiff graft. Until last year, we have done around 700 cases of HUL. And based on my clinical experience, today I'm showing the current indication of HUL for irreparable cuff chair based on the Hamad classification, ultra grade, sports activity, physical work, pseudoparalysis before surgery, and concomitant irreparable subscapular tear. First, Hamad classification. Actually, from grade 1 to 5, all Hamad classification is the ideal for fasciolata HUL, but actually grade 1 to 4B, we do arthroscopic supercapsular reconstruction, but 4B in old patient and 5, we do total shoulder plus HUL. But maybe some doctors do using dermagraft for HUL, but the dermagraft HUL, maybe the grade 1 and 2 are ideal, but the grade 3 to 5 gray zone or contraindication because of lack of super stability, even after dermagraft HUL. I'm showing some cases, Hamad grade 1, after HUL, graft is intact there and good elevation. And grade 3, after HUL, increase acute distance and the graft is intact and good elevation. And this patient had grade 4B in young patient. We did a HUL for this patient, and after HUL, good elevation. But actually, this patient had pseudoparalysis before surgery. And grade 4B in old patient, this patient, we did total shoulder plus HUL. Then, after total shoulder plus HUL, good elevation and good external rotation without any pain. And next, gluteal grade. For any gluteal grade, fasciolata HUL is ideal. This patient had actually gluteal grade 4 in supraspinatus and infraspinatus muscle and subscapularis muscles before HUL. Then 10 years after HUL, graft is still intact, but actually supra-infra subscapularis gluteal grade 4. And 10 years after HUL, still good elevation and good external rotation, and he's still doing carpenter actively. And sports activity, fascial HO is ideal to return to sport in irreparable cuff tears. This patient had 3 tendon tears before surgery, and 1 year after HO, he returned to the baseball. And next, physical work. Fascial HO is also ideal to return to physical work. This patient has 3 tendon tears before surgery, and now he returned to as a gardener, and no pain at all. And the next, pseudoparalysis before surgery. Fascial HO is ideal to recover pseudoparalysis. This is the average data of active elevation. If the patient does not have pseudoparalysis with elevation and around 160 degrees after HCR, and even the patient has moderate pseudoparalysis or severe pseudoparalysis, the active elevation significantly increased around 150 degrees. This patient with carpenter and very limited elevation without any pain, and even after lidocaine injection, he couldn't elevate arm at all. And its MRI shows irreparable massive tear, and 3 years after HCR, graft is still intact and good elevation, and he's working as a carpenter. Next, concomitant irreparable scapular. Now I can say it's a gray zone for Shirata HCR. This is average data of the active elevation. There are no subscapular steer group, the good active elevation after surgery, 155 degree, and reparable subscapular steer group, we did HCR plus subscapular repair, then good elevation around 157 degree in after HCR. But irreparable subscapular steer group, in this series, we did only HCR. We did not treat subscapular tear. Then active elevation, the increase, but actually post-operative active elevation in this group was significantly less than the no subscapular steer group and reparable subscapular steer group. And this patient had irreparable supra and infractional tendon tear with reparable subscapular steer. After the surgery, and distance increased and graft was intact, and repaired subscapular steer is intact. And after surgery, good elevation and good internal rotation. And he returned to the carpenter at 6 months after HCR. And this patient has a supra and infra and subscapularis irreparable subscapular tendon tear. And before surgery, very limited elevation and limited internal rotation. Then after HCR and graft was intact, but subscapularis still no change because we did not treat at all. But actually, the elevation increased and the internal rotation also increased, but muscle strength in the internal rotation, it's not so strong. That's why I can say it's a gray zone. Finally, I'm showing my indication of reverse shoulder arthroplasty, meaning the contraindication of HCR is a failed total shoulder arthroplasty birth defect, chronic shoulder dislocation in old patient, Hamad grade 4B or 5 with irreparable subscapular tear, and irreparable tear in all 4 rotator cuff muscle. Thank you for attention.
Thank you, Dr. Mihata. It's very good information. I always love this surgery since the first time I heard it. We already have a few questions from the audience, and we can start out. Dr. Adinun, do you have any questions? Maybe you can start off with a few.
Yeah, but maybe start from the question from the floor, I think.
Okay. Now, Dr. Mihata, I have one that is quite interesting, that there are doctors that actually advocate using allograft. What is your perspective on that?
Allograft, actually, it's a fascial allograft, or what kind of allograft?
Well, they did not specify in the question, but I
maybe
don't really know.
Okay, maybe dermograft, allograft. It's actually the too soft actually. It's even the very strong, but actually it's stretched very well. That's why the even after HO, they're super migrated. That's why there may be the indication of the dermagraft HO may be good the Hamad classification in the grade 1 and 2 only.
Okay, there's one good question I always wanted to ask you this about tensioning the graft. Can you tell us how do you decide on the tensioning of this graft?
Yeah, tension is very important. So now I'm now recommending based on my clinical and biomechanical research. Then now actually the 30 degree of shoulder abduction, that is a very good tension for SCR. Maybe 0 degree it's a too loosen, but 45, 50 degree maybe too tight, maybe high rate of the graft tear after SCR.
May I have another question related to this question? I saw you set the position like a lateral decubitus, right?
Yes, yes.
Are there any different if we use the chair position?
Maybe they're similar, but lateral decubitus position that is maybe the easier to have this fasciolata. The Nobu Yamamoto maybe here. His position is the beach chair position, but maybe it's a little bit hard to have the fasciolata, but actually he's doing.
There's a question from the audience. During a talk, you talked about the pseudoparalysis being reversed after the SCR. Can you explain a little bit on that?
I'm sorry, once again, what did you say?
The pseudoparalysis after SCR.
Yes, pseudoparalysis, actually, if the deltoid muscle strength is very good or okay, that case, the old patient actually the restored. If the graft is healed, if graft was torn, maybe some patient did not restore, but I recommend to check the deltoid function. Some patient had a concomitant see it's a real test. In that case, the patient can elevate arm after SCR.
Oh, and I actually have another question. This is a personal question. I saw that you had an example of total shoulder arthroplasty with an SCR. How do you anchor that onto the humeral side?
Oh yeah, very good question. Now the femoral side now it's a bone tunnel technique, so we do not use a suture anchor. Yeah, it's an open surgery, so that's why that's very easy.
Oh, like you do hand osseous, right? Hand osseous repair, right?
Like that?
You do like a hand osseous, right? Just put the hole.
Yeah, yes.
Oh, okay. How about your comments about the total shoulder arthroplasty plus SCR and compare with the reverse shoulder arthroplasty?
Yeah, actually, elevation is similar. It's a bone tunnel
total shoulder arthroplasty.
Without the physical therapy,
it's a bone tunnel total shoulder
external rotation, internal rotation, range of motion. Actually, it's much better than reverse. But after reverse, some patient cannot reach to the back, but the total shoulder plus SCR, all patient can reach to the back. So because it's anatomical surgery, so the external rotation and the internal rotation much better than reverse, but elevation similar.
Okay, thank you.
Thank you. I think we are near the end of our session. And thank you again, Dr. Mihata, for a wonderful talk. And everybody for their wonderful questions. It's been very good. And I'll pass it on to our next session. And the moderator is Dr. Lu. Dr. Lu, would you please take over from here? Thank you.
Thank you.
Thank you, Kevin. Thank you, Kevin. This session will be the elbow. Our speaker will be Dr. Wada from Ottawa, Japan, and his talk will be OCD of the Capitellum. Our commander will be Dr. Lee from Korea. So let's begin the talk. Dr. Wada.
Yes.
Okay, thank you.
Can you hear?
Yes.
Can you hear me? Okay.
Yes. Good.
Thank you, Dr. Liu. It is my great pleasure to have an opportunity to give a lecture for young surgeons in APOA. Osteochondritis dissecans of the capitellum is a painful condition of the elbow which often affects young throwing athletes. The pathology is disruption of the hyaline cartilage and underlying subchondral bone of the humeral capitellum. Epidemiology. The prevalence in Japan is reported to be 1 to 3% in adolescent baseball players. The risk factors are found to be begin to play at earlier age, longer duration of competitive play. Biomechanics. In throwing motion, from cocking to acceleration phase, violence torque and rapid extension force was generated, resulted in compression and shearing force to radiocapitellar joint. This repetitive overload resulted in cartilage and osteochondral fractures. Dr. Takahara studied pathology of OCD lesion using biopsy materials. In the very early stage, the pathology is separation of cartilage and subchondral bone. Then calcification and fibrocartilage connection occurs, leading to delayed ossification. Finally, osteonecrosis and separation occurs, and this fragment goes to loose body. Diagnosis. The patient presents throwing-related lateral elbow pain. They occasionally present catching, cracking, and locking. On physical examination, patients have a tenderness over the capitellum and the radial head. A restricted range of motion is often observed. Radiographic classification. There are 3 phases. In early phase, radiolucent phase here, and separating phase and defect phase is accompanied with a loose body. Radiolucent phase corresponds to International Cartilage Society classification OCD1, and separating phase corresponds to OCD2 and OCD3, depending on the stability of the fragment. OCD3 represents unstable lesion, and defect phase corresponds to OCD4. I would stress 45 degrees flexion AP view is crucial to identify OCD lesions, at the lesion located at the front portion of the capitellum. MRI is also important. High signal interface between cartilage and subchondral bone suggests unstable lesion. This is important to determine the surgical indication. A treatment algorithm. A treatment in the radiographic radiolucent phase with stable lesion and separating phase with stable lesion, conservative treatment is indicated. And separating phase with unstable lesion and defect phase are indicated operative treatment. And if conservative treatment failed, it goes to operative treatment. Operative treatment consists of osteolymphasis bone peg, arthroscopic debridement, and osteochondral autograft. If the diameter of the lesion is over 10 to 15 millimeter, osteochondral autograft is usually selected. Conservative treatment consists of discontinuing throwing and sometimes batting for at least 3 to 6 months. This is this X-ray and the diagnosis, the radiolucent phase. At 3 months, ossification occurs at the lateral phase and extended to medial phase. At almost 24 months, complete healing occurs, and this boy returned to a pitcher. Conservative treatment is very effective in early phase. The radiolucent phase healing rate is 90%, and 80% of players return to play. But in separating phase, healing rate and rate of return to play goes down. Arthroscopic debridement. This boy first performed conservative treatment, but it failed. A lesion getting smaller, but not completely healed. Then he underwent arthroscopic debridement. The humerus, capitellum, and radial head. You can see the lesion here. The scope is switched to posterior compartment, radial head and capitellum. Remove the loose body. Debride the lesion. And drilling. So you can see a good bleeding here. Osteochondral autograft is indicated for advanced OCD lesions. We have two kinds of procedures depending on donor site, one from the knee and one from the rib. This slide was provided by Dr. Mihata. Osteochondral graft is harvested from the knee, either using small skin incision or under arthroscopy. Dr. Mihata transferred the graft also under arthroscopy. Debride the lesion and 6 millimeter diameter of graft are introduced, and this is final graft. So this slide was provided by Professor Kazuki Sato. This is the reconstruction using costal osteochondral graft. The graft was harvested from 6 costal osteochondral junction of the rim. The graft floor and transplanted the graft here. The case presentation, pre-op radiograft, 1 year post-op, 3 years, and even in 8 years, remodeling occurs, and he reported a very excellent functional score. The operative result, 72 patients were included, and the average follow-up period was 4.8 years. Over 90% of patients reported excellent results, and almost all patients return to their original sport. In conclusion, OCD of the humeral capitellum is a painful condition of the elbow, which often affects young throwing athletes. In early phase, conservative treatment consists of discontinuing throwing is indicated. In advanced phase, arthroscopic debridement, osteochondral autografts are indicated, depending on the size of the lesion. I really miss this crowded condition, but this will be back soon. Thank you for your attention.
Thank you, Dr. Wada. A great talk. There are many questions from the audience. The first question is, in the case when you have to osteochondral autograft transplantation for OCD, what's your favorite donor and why?
I prefer the rim, costo-osteochondral junction, because we can use this graft even in the big size of the lesions. So this is my one reason why. I don't want to harvest the graft in an intact knee. So this is a second reason.
Okay, this is another question. Very one big osteochondral graft is better than multi-graft. It's a question. Do you think so? And how?
You mean the yes, the multi-graft is, but the recently I usually do a rather big 6 millimeter or 8 millimeter graft in the center of the lesions. So there are some necrotic areas where even it remained, but it's okay.
Okay. Dr. Lee?
Yeah, there are many questions, but by myself, I would like to ask two questions. You said that non-operative treatment should be started before surgery. What is your conservative treatment method, and what is your post-operative rehabilitation method after surgery?
Yes, conservative treatment is very important, even in the advanced stage. The first, we try a stop throwing motion, and sometimes padding, and even carrying heavy materials. And sometimes we ask the rehabilitation staff to change the throwing motion. But it failed. We will recommend reconstruct the procedures or just a debridement.
Do you use a splint or other?
Yes, sometimes. Yes. Sometimes, if there is a fusion in the joint, so we use splint. Yeah.
Thank you.
And use the post-operative rehabilitation. Yes. Yeah. Yes. After the osteochondral autograft, so elbow is immobilized for 2 weeks, followed by RM exercise, and shadow pitching start at 4 months, and full power throwing may be permitted at 6 to 7 months.
Thank you.
So, Dr. Wada, how often is elbow stiffness in your practice for this OCD patient?
How often? Yes.
Yeah.
Yes. Yes. My clinic. So yeah, even 2 or 3, at least one patient a week, at least one.
Okay. So in my practice, the elbow stiffness is a little bit more common than that. And if there is OCD patients have the severe elbow stiffness, what's your treatment approach? Do you do graft?
Stiffness. Yes. If he don't have osteoarthritis, so we observe the patient using sometimes a splint, or sometimes we using a steroid injection, and he goes back to see again.
If you do osteochondral bone graft and elbow release in same stage, do you ever try to?
No.
Yeah, yes. Always 2 stage.
Yes.
Oh, okay. Thank you. So, Dr. Lee, any question?
If we have more time, there is a question. What is your advice to avoid graft necrosis in all procedure for OCD? From the audience, there is a question.
Avoid such procedure. You mean the?
Yeah. What's your tips to avoid the necrosis?
Yes. So it is important the prevention. So Japanese Orthopaedic Society recommendation of limitation throwing to Japan youth and high school baseball federations, and early diagnosis is also important. So medical check, including physical examination or ultrasound sonography for young players, are performed on each community basis.
That's good advice for the prevention of OCD. And the question is tips for avoiding graft necrosis after surgery.
Yes, after surgery. Okay.
Yeah.
So pitching is a risk factor for poor prognosis. So sometimes we recommend change position the pitcher to a fielder.
Same method with the avoid the OCD itself.
Yep.
So we have still time.
Maybe one more question. The last question.
Yeah. Why do you have so many OCD patients in Japan?
So baseball is the most popular sports from elementary to high school boys in Japan. And their aim is to participate in high school baseball championship called Koshien. So they work too hard, sometimes break his elbow.
It's more difficult than Olympic Games, do you think?
Right.
Okay. Dr. Lu, I think it's time's up.
Okay. So the next session is the hand session. The moderator will be Dr. Waitayawinyu.
Thank you, Dr. Lu. Hello, all APOA members and audience. We have learned a lot from 2 sessions earlier. We are heading to the last session of our webinar. Today, our hand session is Kienbock's disease. We have a good opportunity to learn from our great hand surgeon, Professor Bain. Dr. Bain is the professor of upper limb and research in the Department of Orthopedic Surgery, Flinders University in Australia. Currently, he is the president of IWAS, the National Wrist Arthroscopy Society, and the deputy editor of the Journal of Wrist Surgery. He also the former president of the APOA, the Asian Pacific Wrist Association. With over 150 research papers and book chapters on hand, wrist, elbow, and shoulder, including the book Kienbock's Disease, Advanced in Diagnosis and Treatment. Professor Bain, please. And after that, we have Dr. Tan, Jacqueline Tan, who will be the commentator who will collect the question for asking Dr. Bain later on. Professor Bain, please.
Thank you very much for those very kind words. I'd also like to thank the organising committee for the great privilege of being able to provide this presentation. Certainly the whole event seems to be very well organised. So I'm going to talk about Kienbock's disease. I'm going to try and cover two things, what I refer to as the basic science model of Kienbock's disease and our algorithm to approach Kienbock's disease. So with regard to Kienbock's disease, I think it's more about the microstructure of the lunate, the venous drainage, the concept of it being a stress fracture, and the compartment syndrome model of bone than it is about the arterial supply of the lunate. So this is we refer to as the basic science model of Kienbock's disease. So with regard to when we're looking at a patient with a wrist disorder, the patient who is at higher risk of having Kienbock's disease will have a type 1 lunate, which means there's a single articular facet here. The lunate will be smaller. It will be uncovered, which means it's partly hanging over the radius, and there'll be a negative ulnar variance with regard to the length of the ulna versus the radius. If we look at this video here of a fluoroscopy, we can see that when the wrist goes into ulnar deviation, how the volar carpal ligaments become taut, and there's a cantilever force on the proximal aspect of the lunate facet. So if we look at this image with an arthrogram, we can see that in ulnar deviation, it's this area of the subchondral bone plate which is taking all the force. So if we go back and look at some of the microstructure of the lunate, so this is a micro CT of the lunate, we can see that there are these spanning trabeculae that span from the proximal to the distal subchondral bone plates. And they act like these little fellows here holding up the distal subchondral bone plate. And if we look at the forces that are placed onto the lunate, when we put the wrist into radial and ulnar deviation, we can see that in the micro CT specimens, how that there may be a fracture through this area. And interestingly, in this dry bone cadaveric specimen, there's actually a microfracture in the subchondral bone plate of the proximal lunate facet. So it's just 1/10 of a millimetre thick. So it's really at risk of developing this sort of fracture. The coronal fractures that are commonly seen in Kienbock's disease, we think are due to the punching action or nutcracker effect of the capitate onto the lunate. And so we can see where the capitate sits, how this will propagate across towards the triquetrum and cause a coronal fracture of the lunate itself. Interestingly, we can see that this spans across from the ulnar corner of the radius. So this is a normal lunate, a micro CT, and this is a lunate taken out with a proximal row carpectomy, and that we can see that if we put the thing together, we can see that the distal subchondral bone plate is all still present. The proximal is fragmented and there's some bone loss, but the main finding is there's extensive resorption of the endosteal bone of the lunate, and of course there's joint irregularity, which can lead to degenerative changes within the wrist. So the whole concept of the osseous component of the wrist has been covered in the classification developed by David Lippman, and this is an important contribution to our understanding of Kienbock's disease. So I want to go talk a little bit about the vascularity. So Lee published in 1963 that there can be a single vessel and that it can go from just the volar or dorsal aspect, and on 7% of case, there's no anastomosis from front to back. What I think is more important work is the work by Harry Kroc, looking at the venous drainage of the lunate. And what he did was, in his studies, he demonstrated that there was a series of subchondral plexus, which were parallel venous drainage systems on the proximal aspect of the lunate, and that wherever there was, potentially wherever there's a fracture, we've postulated that if this fracture occurs here, that these parallel layers of venous drainage could be obstructed. In addition, if there was an obstruction of the exiting veins at this level, that this may lead to a complete venous obstruction for the entire lunate, which is similar to David Lippman's concept of a type 1 lunate. So if we put together the venous drainage concept and the micro CT of this proximal lunate, and we look at the micro CT structures, or these specimens here from from Harry Kroc, we can see that the venous drainage sits in these little gutters adjacent to the subchondral bone plate. So if there's a fracture through this level here, this will lead to a localized obstruction of the venous drainage and localized avascular necrosis. So the concept of compartment syndrome of bone is not a new one. And we know the lunate is a small single bone. It has an arterial inflow, and inside there are sinusoids and a venous drainage. In the normal lunate, the arterial supply is about 60 millimeters, and we know that it's uncommon even in lunate fractures to get avascular necrosis. But what's interesting is the venous drainage of bone, including the lunate, is very low, like 5 or 10 millimeters of mercury. And so if there's any venous obstruction, that's going to cause problems with regard to the lunate. We know that from the interesting work of Jensen, where they put a needle into the lunate, that the pressure inside the lunate can be as high as 150 millimeters of mercury. So there's clearly a great increase in pressure, particularly when the wrist goes into extension. With regard to localized ischemia within the lunate or any bone, the fat cells become very distended and very swollen. And what these fat cells do then is that they will tend to obstruct the venous drainage. We know from microsurgery, if there's any obstruction of the venous drainage, the flap will die or the finger will become necrotic. And so the venous drainage is a critical component, particularly of any form of necrosis and particularly avascular necrosis. This is the specimen from a proximal row carpectomy. And again, we can see the fractures through here. We can see this subchondral bone has all been reabsorbed. But the most interesting finding is that these new pillars of bone on the volar and dorsal aspects of the lunate trying to revascularize the lunate. Particularly in the younger patient, there's a real opportunity for that lunate to become revascularized, similar to what we just saw with regard to the capitate in the elbow, capitellum in the elbow. So particularly those that are younger than 20. Rainer Schmidt did an interesting study where he's looking at the intravenous gadolinium to demonstrate enhancement of the lunate. So the gadolinium is taken up in the lunate, and this classification concept is a way to assess the vascularity of the lunate at the prior to performing surgery. So all these concepts relate to the vascular aspects of Kienbock's disease. So we have these different components, the etiology, which I think are more important than the arterial supply of the lunate. This we refer to as the basic science model of avascular necrosis. I'd like to point out we've looked at this also with regard to the lateral condyle of the distal humerus, and we think the same principles apply, and we've also looked at it into the proximal humerus. So what about the articular cartilage? The articular cartilage is important in all articulations, and we can see in this arthroscopic image there's lots of ulcerations and sclerosis. In this proximal row carpectomy, interestingly, the lunate facet doesn't look too bad, but the bone in between there has completely been eroded. So this arthroscopy here demonstrates a patient with Kienbock's disease, and we can see there's irregularity, clefting, and exposed bone. And we refer to that as a functional articulation. Sorry, non-functional. And we come across here to the scaphoid facet. I'm just going to play that again, I'm sorry. So if we look at the lunate facet, what we can see here that it's rough and irregular, and using our classification or concept of assessment of the articular cartilage, we would refer to this as a non-functional articulation. When we come across to the scaphoid facet, we can see the normal, smooth, glistening surface, and we refer to that as a functional articulation. Based on that principle, where the functional articulation and the various articular surfaces in the central column, they range from 0 being that all articular surfaces are intact through to all 4 articular surfaces are compromised. This classification we published in 2006. And based on these findings, including whether the lunate was fractured or whether there was degenerative changes, we made recommendations using motion-preserving procedures to try and get the best outcome for these patients. We recently published our long-term results looking at the results of this, and we're very pleased to be able to report that we think that that's a useful technique to assess patients with Kienbock's disease and apply those management algorithms. So these are the articular aspects of Kienbock's disease. So there are 3 classifications that have been developed for Kienbock's disease. David Lippman's classification, our classification on the articular surface, and finally the vascular concept developed by Schmidt. So if we look at these three classifications, and you may consider how you look at your patient with Kienbock's disease, this is what you may see and how you may interpret it. This is how you may classify it. But this is how we are trying to interpret the lunate, how it works with regard to these three components. And this is how we're trying to look at the concepts of how the lunate is diseased and how it affects the wrist. So this concept of trying to put all these aspects together, consider the lunate and the entire wrist. And I'd like to acknowledge David Lichtman. The two of us together put together these concepts, which are published in this textbook on Kienbock's disease of the wrist. The concept that we developed, the Lichtman-Bain algorithm, looks at the age of the patient. We know in the elbow and also in Perthes disease, with avascular necrosis, the young age of the patient is a good prognostic factor. Looking at B, the bone, the lunate bone, and C, how does it affect the carpus? We also looked at D, what can you do as a surgeon? Well, we think most people can do arthroscopy or an osteotomy, proximal row carpectomy, limited wrist fusion. Vascularized bone grafts may be a little bit more complicated, but there are things such as arthroscopic complex reconstructions, fixing the necrotic lunate, free tissue transfer, or implant arthroplasty in the wrist. These are more complex procedures. We feel as though that these should be dedicated to specialist units and for them to advance this science and then hopefully teach us all about it. But really what I want to concentrate on today are the techniques that we can use in everyday practice. So the green ones, the ones that pass the test of being available for all of us to use in clinical practice. So with regard to A is the patients who have a better prognostic age. So we know that those that are younger than 15 or even younger than 20 will do well without surgery. So most of these patients do not go to surgery. An interesting observation is that those that are older than 70, they often do well as well. They may have poor looking x-rays, but in fact, these patients do well without surgical intervention. And if they did need surgery, it would usually just be an arthroscopic debridement. So if we've got a patient who's young, then what we're trying to do is if we need to do surgery and they fail at least 6 months of non-operative treatment, then we may do an epiphysodesis, or we maybe even consider an STT joint pinning to unload the central column. Now looking at B, which is the lunate. So we start here with when the lunate looks intact, when we have a nice healthy lunate, what we want to do is protect that lunate. If the lunate is compromised, so it's a bit rough and a little bit irregular, then we may look at reconstructing it. And clearly, if it's not reconstructible, then we need to look at doing a salvage procedure for the lunate and maybe a salvage procedure for the wrist. So if we go on to the B1, which is where the lunate is intact, if the lunate, we have a negative ulnar variance, such as in this example, then a radial shortening osteotomy would be a standard of care. For those patients where there's a neutral ulnar variance, then other options should be considered, such as a capitate shortening, STT joint pinning, and some of our Japanese colleagues have taught us that if there's a marked increase in the radial inclination, then a closing wedge osteotomy may be indicated. The technique that we're now using is what we refer to as a single cut osteotomy of the radius, using either an oscillating saw or a side cutting reamer to perform an oblique osteotomy, insert a cannulated screw, and that these patients just require a splint after all the periosteal tissues are all intact. So this demonstrates an example of using the technique. We can see here that where the osteotomy would be at the initial stage, this patient is 1 week since the surgery. We can see where this small incision is here. There's almost minimal, very minimal swelling. The patient just needs a wrist splint, and then they can start getting it moving. And we can see that the osteotomy is going to simply heal. But what's interesting to see is how much improvement the patients get with regard to their pain relief. The other technique that we like to use is a capitate shortening osteotomy. And the technique is similar to some of the concepts used in scaphoid fracture internal fixation. We insert a wire and a cannulated screw. We use a narrow reamer to be able to remove some of this bone at this area just to shorten up the capitate. And it's important that it's a little bit more distal than you would first think to protect the neurovascular structures or the vascular structures that come into the capitate. and then a cannulated screw is put into this interval to be able to close the capitate and lock it into position. So we can see this is the sort of final position we would obtain. We like this technique. It's a reasonably simple technique to perform. It's extra articular. The other option is to put the screw up through the articular surface here, but that requires to really force the wrist into flexion. And with the lunate being a bit compromised, we're concerned that that may lead to more fractures of the lunate. So we think this is a better way to do that. So going on to when the lunate is compromised, when we're looking at doing a reconstructive procedure, we may look at using a cancellous bone graft or a vascularized bone graft. I think this is the more difficult group. The free tissue transfer to be able to transfer from the medial femoral trochlea can be performed, but this is an advanced technique. And in our hospital, free tissue transfer is usually reserved for cancer and limb-threatening conditions, not for a sore wrist. So if we go back to the arthroscopy, we can see how the whole lunate subchondral bone plate is floating up and down. And this is because we've created a distraction across the level of the wrist, and so that there's a defect in that lunate, and it's because of the traction that's been achieved for that. So this false floor can be detected. So we think that this is the sort of case that maybe we look at using a multimodal approach. The articular surfaces are intact, so we think we need to use something like a joint leveling procedure, maybe a vascularized bone graft. So there are many types of vascularized bone graft reported. The easiest one is the HUL technique, which involves taking the dorsal first to second intermetacarpal artery, and that this can then be advanced and put into the lunate. So the multimodal approach involves unloading the lunate using a vascularized bone graft and also a K-wire for protection. So we can see here this K-wire between the scaphoid and the capitate protects this lunate and then the vascularized bone graft. Now, this concept of multimodal approach is not new. It's used in rheumatoid arthritis, tuberculosis, and cancer. You know, in the rheumatoid arthritis, the patients now get many drugs to start with as their treatment, as their initial treatment. So once the lunate is fractured or compromised, the other option is to consider internal fixation. At first thought, this seems an obvious thing to do, but clearly with the sclerosis and avascular necrosis, this becomes more difficult. I have very limited experience in this, but I know that there are some surgeons that like to do this. And if you are going to do it, I think you should be considering a younger patient with a two-part fracture and where you've demonstrated the vascularity has been provided, maybe with an MRI perfusion scan. I'd like to acknowledge Mark Barrett, who's provided this case for me. We can see here that he's performed an arthroscopy and a debridement, and he's put K-wires across here to provide initial stability. And you can see again this multimodal concept of a K-wire going from the scaphoid to the capitate so that he unloads his internal fixation. So once it becomes a bit more compromised, where it's not just affecting the lunate, but it's now affecting the entire carpus, things become more difficult, and we're looking at a salvage procedure for the lunate. And examples include the proximal row carpectomy. This is a reasonably simple procedure that I think all wrist surgeons can perform. And we tend to like this, particularly in the older patient. We know that the younger patient who's younger than 40 with higher demands, that they may wear out their proximal row carpectomy. In the younger patient, the scaphocapitate fusion is often considered, and this involves screws between the scaphoid and the capitate and some local bone graft. And for the higher demand patient, this is probably the correct procedure. So we just look at this in a little bit more detail. With the scaphoid being extended, this now takes the load through the radial column, and you can see this loading in the subchondral bone plate while the lunate has been protected, and you can see that there's some unloading at this aspect. In fact, the lunate looks a little bit higher. So this technique we think works well, but it's important that the details of this procedure are done correctly. So with regard to this algorithm, if the patient is younger than 20 or older than 70, non-operative treatment is usually instigated. If the lunate is in good condition and it's intact, we like to either perform a single cut radial shortening or single cut capitate shortening osteotomy. If the lunate is compromised, we look at doing a multimodal approach. And finally, for a motion preserving procedure, we look at a proximal row carpectomy or a scaphocapitate fusion. I'd like to finally share with you some recent work we've done on 4D CT scans, which has just been published. And one thing that's interesting, as the wrist moves in the scanner, we can see the impingement on the volar aspect of the scaphoid or radial facet. This wasn't something we'd previously predicted. And we can see in this particular example here how the lunate is very fragmented, but we can see that the proximal and distal subchondral bone plates are moving in different directions and that there's movement through this lunate. So the way that this is affected in the wrist is more complex than we first thought, and I think further work's required in this area. So if we look at this particular example here, we can see the lunate is becoming wider, so there's an instability of the wrist through the substance of the lunate. There's ulnar translocation of the carpus, and interestingly, there's ulnar styloid impingement. So now we're starting to look at our patients a bit more closely. We know that some of them have ulnar-sided wrist pain. We also know that some of them have STT joint arthritis. And so we're trying to be more direct where our treatment algorithm is taking us based on the patient's clinical symptoms. So now this is the dynamic component of Kienbock's disease. We've talked about the articular cartilage, the bone, and the vascular components, but this is the dynamic component. So our understanding of Kienbock's disease, well, we have the osseous component, the articular component, and the vascular aspects as well, as we've discussed. But the microstructure of the lunate, we think, is also important. We think the venous drainage, the concept of compartment cinema bone, and finally, the dynamic component of Kienbock's disease. All of these things need to be taken into account with the assessment and understanding of Kienbock's disease. So I think at this stage, we're finding a lot more answers, but we're also increasing the number of questions. But the dynamics have got to be important because it affects how it loads. It affects how it collapses, the impingement. It affects the instability of the carpus. All of these things we know are important with all other conditions of the wrist. So this is the basic science model of avascular necrosis. Thank you very much.
Thank you very much, Dr. Bain. It's a very impressive talk. We learned a lot from you. I'll pass this to Dr. Tan. Jacqueline, do you have questions?
Yeah, Greg. I think there are two questions for you. One is from Sylvia Proper asking, how much does ligamentous laxity leading to increased physiological ulnar translation and subsequent ulnar leg abutment play a part in the development of the injury?
That's a good question. I must admit, we've never looked at ligamentous laxity in Kienbock's disease. It's well known to be associated with other aspects. It's interesting, we spoke before about the Japanese having a higher incidence of the capitellar avascular necrosis. My experience with the avascular necrosis in the elbow is that often there's some instability there as well. I think we should probably look at that a little bit more. I think that's a good question. I don't really have a proper answer to that, I'm sorry.
Okay, another question is, how does capitate shortening affect the carpal biomechanics?
That's a good question too. So by shortening the capitate, it decreases the load onto the lunate. And the initial studies all looked at taking 2 millimeters of the capitate out. And if you look at those original studies, you'll find that with the shortening of the capitate that much, the capitate does not even articulate with the lunate. So we've gone to using a single cut technique. It's technically simpler, but also it doesn't then affect the kinematics of the carpus as much as what other techniques. I must acknowledge Professor Moritomo from Japan, who's done some outstanding work looking at the kinematics of the wrist with capitate shortening. He would recommend using like an L-shaped osteotomy of the capitate. And his rationale is that part of the shortening is then limited only to the lunate, but then the capitate does not affect how it impinges on the scaphoid. The effect of that is that it doesn't tend to get as much flexion of the scaphoid with his technique. We've not noticed that to be a big problem, but that's an important paper if those who are interested in that concept.
Okay, thanks, Greg. So I also have a question for the single cut osteotomy of the radius, the oblique cut. How much do you take and how do you achieve that shortening?
Yeah. So when we first started doing it, we used an oscillating saw, but now we use it's like a reamer. It's what the minimally invasive foot and ankle surgeons use when they do a hallux valgus osteotomy. And so it's a side cutting reamer, and we use the one that's about 2 millimeters wide. So it takes 2 millimeters out. So the advantage is it's a single cut. We just go straight through and just take it at that one level. So we're not trying to do double cuts and get everything to lining up. We take the one cut out and shorten it up. And that way it tends to just change the biomechanics a modest amount. And the other component that's probably important, I think it leads to a regional increased vascularity. So some of you may be aware of techniques that come out of South America where they do a farage of the radius. So they literally put a drill hole into the radius, and that is thought to increase the vascularity. So in concept, we like that, but it almost feels a bit like a sham operation. And so I think if we can use the concepts they have taught us, but link it into other biomechanical principles, so we get the advantage of what they're trying to teach us, plus we get the biomechanical advantages of radial shortening or capitate shortening. I think that's a much more sensible or scientific way to go about it. And then we're giving an advantage in 2 or 3 different ways by doing it that way.
Okay, thanks. There's another question.
Yeah, my question is, for the B1 patient, how would you select between the unloading and revascularization or decompression at the lunate?
So what I like about it is that we get that regional hyperemia and revascularization, and we get the biomechanical effects. I'm not able to tell you exactly how much each component is there, but I do know that the radial shortening is a good operation. And in fact, when we first started talking about all these arthroscopic concepts, we would have some very senior surgeons say, wait a minute, why don't you just do a radial shortening for everyone? We didn't think that was right, because some patients will have a fair degree of erosive or degenerative changes within their lunate and the lunate facet. And so we try and direct the treatment to the right patient. I think that's the important thing. In the past, we'd go to a meeting and everyone would just say, I do vascularized bone grafts or I do a radial shortening. I think one of the most important things we're trying to teach is that you should assess your patient and do the right operation. In the same way, if you had a patient with a slack wrist, you would maybe look at doing a limited wrist fusion or a proximal row carpectomy, and you would really assess that in a bit more detail. We think some of those principles should also be used when you're assessing your patient with Kienbock's disease.
Thank you.
Okay, so another question is for the unloading of the scaphocapitate K wire of the STT-K wire, how long do you keep it, and how long do you think immobilization is required post-op?
So it would be typical for us to leave it in for 3 to 4 months. Basically, we want to get to that stage where the bone has had a chance to heal. So one of the problems we've seen with vascularized bone grafts, and I tend to get emails probably every 2nd or 3rd week from someone literally all over the world with regard to their cases. And the cases that people seem to be having trouble with is when they're doing a vascularized bone graft, because you put a drill hole in it, you put some bone graft in it, and it tends to soften up the lunate, and it gives a flush of blood into there. So I think you get more reabsorption of the lunate. So that lunate really does need to be protected for that probably 3 to 4 months after that sort of procedure.
Do you do any imaging post-op to, monitor for revascularization? Because sometimes when I do MRI, I don't pick up anything.
Yes, so the important thing about that MRI I showed you, it's when we use gadolinium. So for those of you who do shoulder surgery, you'll know you put gadolinium into the joint sometimes to show the detail of the joint. This is intravenous gadolinium, and so it's a perfusion study. We don't do that post-op. We might do a CT scan, or we do plain X-rays. Certainly if we're doing limited wrist fusion, we might do a CT scan to confirm union. We don't tend to do revascularization studies, partly because we don't think we should put a patient through those things unless there's a problem. So if they have pain or they have an issue, then we would do further imaging. But if it was just to see that the vascularity is there, we haven't done that.
And you mentioned this multimodal treatment. When do you decide to do everything for the patient? That means revascularize, unload it, distally, and
probably when we're a bit desperate. So what I'm pleased about is, if anything, if you look at the things we've put into the equation now, we're trying to do more minimally invasive surgery. We're trying to do more extra-articular surgery. So we're trying to change the paradigm. Instead of doing, these patients with big open cuts all over the place and complex 5-hour operations. We don't think that's what we should be doing. We think it should be more specific to, maybe the capitate shortening or the pinning. So trying to do more of those simple things. But if the patient's got quite a lot of loss of the height of the lunate, they're really collapsing down the carpus and they've got a lot of pain, then that's the type of time we might use a multimodal approach. And I must point out the multimodal approach, it's not like we invented that. That's, if you look back at the other papers, you'll find that many other authors over the last 30 years have actually used a multimodal approach. The thing that we've probably done differently is put a label to it, said, that's a multimodal approach. And it's partly just to highlight that it is a little bit different and highlight that, what is really being done with that procedure. It's just a different way of looking at it. But I think it's an important concept to try and to understand.
I think one of the last questions from the audience is, do you remove the lunate when you perform limited fusion?
That's another good question. So if you take the lunate out, we think there's more likely to get an ulnar translocation of the carpus. David Lichtman's view is a little bit different to mine in a way here. So David would say that if the lunate is really fragmented, you should take it out because it partly elutes or brings out some of those toxic type chemicals from the necrotic bone. But we think it does cause some ulnar translocation. So we're tending not to take it out if we can.
Okay, still have time for one question.
Okay.
So any thoughts on unloading the lunate using an internal distraction plate from the radius to capitate or metacarpal base?
Yes, so it is another. So there are papers that have done that where they put like a bridging plate across it. I haven't really gone there because I feel as though it's quite an invasive thing, and if you were the patient to have a spanning wrist plate across. But again, I suppose that's part of the extension of the multimodal approach. And if you had a patient who's 21 who you're really having a lot of trouble with, maybe there's a place to use a bridging plate as linked in with your multimodal approach. So in fact, the pin between the scaphoid and the capitate is an unloading wire. And so that's like a bridging between the mid-carpal joint. So the formal bridging plate could be used, and maybe if there is a place to use it, you'll use that for a shorter period of time, take that off at, say, 6 or 8 weeks, and then still leave the scaphocapitate wires. And maybe that's the algorithm if that was to be used, but I haven't been using that.
Okay. Thanks, Greg, for the wonderful lecture and as well all the questions that you've answered. I'll leave Dr. Thanapong to close the session.
Thank you. Wonderful, brilliant, for the wonderful talk and discussion. Thank you, Dr. Bain and Dr. Tan.
Thank you very much.
I think the time's up. Yeah, I'll pass this to Dr. Ma for the
Thank you so much, everyone. Especially what a wonderful discussion and and the details of presentation by very high caliber speakers. Thank you, commentators and moderators, for your interactions. Can I ask everybody to turn on their camera now? As the organizing committee, we'd like to have a group photo of all of us who are attending this inaugural webinar series for the APOA Hand Upper Limb section. So leave your camera on, and Ying-Ho will then take a couple of pictures for us. I'll keep talking while you're doing that. Now, also, there would be, we in fact have over 200 attendees today, and this is 3 times the actual financial members of our association. And just about financial member, I'll invite all of you who are not members yet to join us. If you are members of APOA, all you have to do is pay a one-off membership fee of $50 and you become a permanent member for life. So that's a good bargain from that point of view. thirdly, there will be a survey sent out to all participants. If you wish to give us some feedback, be most appreciated, and also to get your certificate of attendance as well. Now, Ying-Ho would like to tell us about the next webinar, which is going to be on the 2nd of October. Just for background for those non-members, the Hand Upper Limb Society is very focused on education for younger surgeons. And hence, the society have a 3-year webinar series, all organized to cover just about all the important aspects of hand, elbow, and shoulder surgery. So in effect, by the time you finish your 3-year webinar series, you've done every single sessions, in effect, you probably have done a virtual fellowship in many ways, and then allow you to then take part in our fellowship program, which will be set up later. So Ying-Ho, would hand over to you to tell us about the next webinar.
Sure. Erica, can you share your screen? Let me introduce our upcoming webinar for a minute. Our next webinar is very interesting talk about arthritis. So as you can see here, our next webinar is focusing on the arthritis of the upper extremity. We have a special guest speaker from France, Dr. Pierre Mansard, who is an excellent total elbow surgeon and also a hand surgeon, is going to present current concept of total elbow. And we have excellent speaker from United States, Dr. Romeo, and President of Japan Shoulder Society, Dr. Ikegami, is going to talk about how we can deal with shoulder arthritis in young patients. And also we have the PIP volar arthroplasty and toe to finger transfer in hand session, which will be in the 5th of October. So I hope many of you can join, and please mark your day for our next webinar. And the next slides, please. And also, I do appreciate the sponsoring company of Stryker and Pfizer, which are always supportive to our APOA hand and upper extremities. Okay, over to you, Dr. Ted.
Well, thank you so much, Ying-Ho, and thank you all again for your participation in this very wonderful discussion. I think everybody have learned a lot from all the speakers. In particular, thank you, Greg, my fellow Australians, for being such a innovation in Kienbock disease. So bye now from all of us, and I'm sure we'll meet again soon. I hope you enjoy the APO Congress, and there will be a few more sessions. In fact, there will be a closing ceremony in about an hour's time. So for now, goodbye and take care.
We will keep the link open for the participant to finish the post-webinar survey just for a while.
Do we have still Greg here? No. Okay. Oh. Yes, Margaret. Sorry about that.
It's okay. I didn't want to jump in, so it's okay.
Very sorry about this.
Sorry, Margaret, I did forget about your introduction for your session. Margaret, what we can do is that at the survey, we send out the flyer.
Okay, yeah.
That would be great, all right?
Okay, thank you.
I have to say, that was great. Thank you very much. I learned quite a bit about the elbow and hand, things that I'm not very familiar with. Thank you.
I think a lot thanks to the speakers, but also the attendants who actually asked the relevant questions. I think that's very important. In HUL, we have a lot of participations from APOA sites, which is great.
Yeah. I think over 200?
Yes, very good.
Not like any other sessions, I mean.
I think hopefully we will get some interest, people who want to join us.
Yeah, sure.
Oh, somebody asked, how do we join the membership?
Okay.
Oh, great.
Send an email to yeah.
Erica, could you answer? Is there a link?
You
need to find the link now.
Is this Erica who uploaded that question?
No.
I think I'm not sure how many of you have been taking part in the APOA Congress last few days. Our Zoom meeting seems to be very clear. We don't have much technical problem as compared to the APOA session. In HUL, do you have the same feeling or you have the same problem?
Yeah, I mean, I joined the APOA first day and second day, and we didn't have a much, Q&A. Not many people actually joined. Even my plenary lecture yesterday was just the video streaming and finished. But today it was very, dynamic and active. You could find a lot of questions from the participants, and we didn't have any pause at all. So I think it's a very successful webinar. What do you think?
Yes, the difference is we are running a real-time webinar, whereas APOA are running a video.
Yeah.
So now we have pre-recorded video for every sessions. And where there lies a problem is a technical issue. In other words, the streaming speed, the speed of the video streaming will depends from the organizer, and then also depends on the receiver. If the receiving end, your internet is not able to cope with the speed that we require to show the streaming, you're going to get a lot of disruption in your images. Not so much the sound, but the images you may have. That's what I found at the very beginning of the opening ceremony, where there were about 1,000 attendants receiving 3 concurrent streaming. And that's where the technical